know really answer this issue?
I don't know, sir, at the moment. But I think it's something. I think that's very important. If there's any GP, those GPs who's in the GP shared care have any issues, any questions, or any communication breakdown, is there somebody that GPs can call? Now, based on this shared care program, there is a number that you can call. It's apparently the nursing unit manager in the antenatal clinic. That's what was written. Was that your understanding?
They are the ones who are doing all these things. They want the patient to go back to the GP.
Correct, yeah. Can GPs contact you or to sort of, resolve those issues in terms of the communication?
Yes. I'm happy for GPs to contact me and to raise those concerns, and I might talk to some of you at the end. We're aware of some of the issues. Some of them are solvable and some of them seem not to be, but the hospital does have a strong desire to see it work because they can't, they're under a lot of pressure with the number of babies being born, but also the projected population growth in the area. So they would like for that to happen, but it's a matter of driving that systems change within the hospital.
I think what I'll do is I will go back to the hospital and have a chat with our director of the department to see whether she would be interested in. I think there should be where GPs can communicate, ask for clinical questions, or ask any relevant question in terms of the GP shared care, so that some sort of communication lines can be set up. That's what I'll do to my director of the department. And then I'll feed back to Yolanda. Do you think that will be okay? Anything else? Keep going? Okay. Okay. So there are some things developed over the last few years in antenatal care. But mainly, I think these two are new. From the aneuploidy screen point of view, non-invasive prenatal screening, and then pertussis vaccination program. So I will go through these two. So non-invasive prenatal screening. Now, non-invasive prenatal screening, I'm sure a lot of people know this. It's basically the blood test introduced in Australia for the last few years. So basically what they do is that they take the blood from the mother. And the technique is they identify what they call free-fetal DNA in the maternal blood. And then they can let you know the risks of the baby being aneuploidy. There are types of the free-fetal DNA. There's something called fetal DNA fragment from the trophoblast cells, or what they call free-fetal DNA, which come from the apoptosis of the fetal cell, circulating maternal circulation, and then fetal mRNA coming from the placenta. Now, these free fetal DNA is present between 5 weeks gestation to the birth. Its half-life is 16 minutes. And then it accounts 3 to 10% of the total DNA in maternal circulation. Now, these free fetal DNA was discovered in 1997. At early stage, the technological restriction only allow the detection or the exclusion of the singular allele. So they used this technique for, these are the example, fetal sex determination, or fetal RHD status, or diagnosis of the certain genetic condition where the diagnosis can be done using single allele genetic test. But somewhere in the mid-2000s, they developed a new technique called next generation sequencing. It is a technique where they can count many DNA sequences very fast, simultaneously. And that led a development of what they call non-invasive prenatal screening for aneuploidy. So from 2011, commercial labs started the detection of the trisomy 21, 18, and 13. And by 2013, more than 2,000 NIPS are happening per day worldwide. Now, there are 3 types of the technique. And then there are different commercial labs using different techniques. I'll briefly go through with this. There's a technique called shotgun massively parallel sequencing. This basically is a technique where they identify, count large number of all fetal, all maternal free DNA in the mother. And if there is a fetal aneuploidy, for example, trisomy 21, there will be more trisomy 21 DNA. So there is an excess. If it's a Turner syndrome, there will be deficit of the fetal sex chromosome. So there's a deficit of the chromosomes in question. Then they developed this technique called targeted massive parallel sequencing. So what they did, they don't look at all chromosomes. It's a technique where they identify and count selective DNA fragment. In this case, chromosome 21, 18, 13, and 21. So they count both maternal and fetal DNA just for these 3 or 4 segments. And again, if there is a fetal aneuploidy, there will be either excess or deficit of the chromosomes in question. And then there's a technique called single nucleotide polymorphism-based approach. Again, this is a technique where they can just identify the fetal DNA because the fetal DNA contains the paternal DNA. And then it goes into a special algorithm, and then they decide whether there is an aneuploidy or not. So, what are the performances are like? Now, this is the most recent meta-analysis looking at all tests, all studies involving NIPS. From trisomy 21 point of view, the detection rate is very good, 99.2%. It's a very good sensitivity, with a false positive rate of 0.09%. I think this is excellent. Trisomy 18, detection rate 96%. Again, low false positive rate. Trisomy 13 is a bit low, 90% detection rate. In other words, 10% chance they miss trisomy 13. Monosomy XO, Turner syndrome, 93%. I have to say overall, the detection rate is not too bad. In other words, you do the NIPS, if the test comes back normal, you can reassure the patient pretty confidently, especially from the trisomy 21 point of view. But if it comes back positive, what are the positive predictive value? From trisomy 21 point of view, it's about 50 to 80%. Trisomy 18 to 13, lower, 20 to 60%. So if it comes positive, you have to confirm the diagnosis with a diagnostic test, such as a CVS or MNU, before you contemplating the determination. At any stage, if anybody has a question, please let me know. Now, why trisomy 13's performance is not good? So, studies say the detection rate or sensitivity ranges around 80 to 90%. Why? There are several biological reasons. Apparently, chromosome 13 has a low guanine and cytosine content in chromosome 21, and apparently that leads to some sort of a sequencing bias. Now, fetal fraction of the trisomy 13 is often low, and then incidence of the trisomy 13 is low anyway. So, number of the studies involving trisomy 13 fetuses are low. So, we do need more studies to quantify the accuracy. Now, when we order NIPS, there is a chance of NIPS comes back as a failed test or inconclusive test. about 0 to 4%. And it all depending on fraction of the fetal free DNA. For the test to perform, it should be around 10%. But if you do it too early, especially before 10 weeks, often the fetal fraction is low, so it comes back as a failed result. Or if the mom's a very large patient, often their fetal fraction is low. So it is recommended that NIPS is only done after 10 weeks. If the patient is very large, maybe later gestation, 13, 14, 15 weeks. Also, these things affect false positive result. There's a condition called placental mosaicism. So at the placenta, there's one cell line, which is normal. There's another cell line, which is abnormal. Could be trisomy 21, trisomy 18. So this abnormal cell line produces abnormal free-fetal DNA. Therefore, false positive result. Now, chance of the placental mosaicism in normal pregnancy is about 1%. So it's something that you cannot ignore. Another reason to have a false positive result, twin, especially vanishing twin. So somebody become pregnant, DCDA twin, and one twin died. And often the reason that these twins die is it's got aneuploidy. And then there's still some trophoblastic tissue generating abnormal DNA, leading to abnormal NIPS result.
In that case, the amniocentesis also could be having the abnormal DNA?
No.
Could you repeat?
Yes, the question is, in this case of the vanishing twin, if we do the amniocentesis, does amniocentesis shows the abnormal result? The answer is no, because when we do the amniocentesis, if it's a DCDA twin or MCDA twin, they have two different sets. And then hopefully it's a good person, we go into the right set and they get the right sample. So the answer is no. Amniocentesis is a diagnostic test. So it shouldn't cause a wrong result, unless you sample the wrong one. Any other question? I'll keep going. Now, so this is a theoretical table looking at the different way to screening Down syndrome. Now, suppose there is a 100,000 women. In general, the incidence of the trisomy 21 is a 0.2%. So they say that there's a 200 trisomy 21 babies. In other words, there is a 99,800, where's my arrow? 99,800 normal baby. And these are different ways to screen the Down syndrome. Now, before the nuclear came, 20 or 30 years ago, we can only rely on the age. So a lot of the time, what they did is a woman more than 35-year-old, they recommended amnio. If you do that, detection rate 30%. So you only detect 60 out of 200 trisomy 21. Overall, the false positivity rate was 5%. So you get 5,000 unnecessary amnio. And then somewhere around the mid-90s, they developed something called second trimester serum screen. So somewhere between 14 to 18 weeks, they took some hormones, beta-HCGs, PAP-A, estradiol, and they made an algorithm to give you the probability of the baby being Down syndrome. This particular test has a sensitivity of 65%. So you do detect more Down syndrome, but still 5% false positive rate. 5,000 unnecessary amnio. Then they developed this NUCLE program, combined first trimester anti-screen. So it's a test that they measure the thickness of the baby's neck. They took some samples from the mother, checking some beta-HCG and hormones, beta-HCG and PAP-A, and they generate the probability. This particular test, which is still being used, has a detection rate of the 90%. So you detect 180 out of 200. Still you're missing 20. Again, same false positive rate, 5%. 5,000 unnecessary amnio. And then last few years they developed a better NUCLE. So out of new, and then basically they added 3 new markers. something called nasal bone, blood flow in the ductus venosus, and then presence or absence of the tricuspid regurgitation. If you add these three markers, it does improve the detection rate, almost 97%. So quite good. And then better false positive rate, 3%. So still, it's like 3,000 unnecessary MU. Then there is NIPS, very, very good detection rate. So almost all trisomy 21s are detected. And a very low false positive rate, very little MU. So, without thinking about the cost, in terms of the screening tests of the trisomy 21, I think NIPS is the best. But unfortunately, it's very expensive.
The one that's being done is the second one or the third one?
In Nepean Public Hospital and a lot of places in Nepean area, this is what they do. For somebody to do this, the sonographer has to go through very rigorous accreditation system looking at the nasal bone, ductus, and tricuspid regurgitation. And not many sonographers can do that. There are good sonographers who do this. Okay, so if the sonographers are qualified, then you can do this. Okay, but in general, for example, in Nepean Public Hospital, they do this. So, for example, in the Penrith ultrasound room, another sort of a tertiary private center, I think they go up to the nasal bone. So those sonographers don't do the ductus venosus and tricuspid regurgitation. I think in Nepean Public Hospital, there's only one sonographer who are qualified to do the ductus venosus to use the algorithm. So it's not easy. Any other questions?
So which is the triple test?
So this is what they call second trimester. Triple test is this. So the question was, which is the triple test? This is a triple test. Some people use quadruple test, depending on which lab you use. Any other question? I'll keep going. There's 100 slides I prepared. I have to go. So we go through some of the advantages and disadvantages of these things, a little bit more detail. So this is a nuclear, combined first trimester screening. So what are the advantages? I mean, I have to say, it does have a good, reasonable detection rate. 90% for trisomy 21, 18, 13, with a 3 to 5% false positive rate. And it's Medicare covered, Nepean hospital free. A lot of radiology centers provide bulk bill services. It does provide accurate dating. I think that's important. And then for the multiple pregnancy, it's very important to diagnose chorionicity. And this is the time that they can tell you whether this is a DCDA or MCDA. After 16, 17 weeks, it can be very difficult to differentiate MCDA or DCDA if they didn't have early dating or nuclear. And then you can check some of the anatomical problems, like a very thin nuclear, often associated with a heart problem, anencephaly, gastroschisis. Those are the things that which they can look around 11 to 13 weeks. And because they are doing some biochemical tests, especially PAP-A, and if the PAP-A is low, often they are associated with the development of things like a preeclampsia or IUGR later in the pregnancy. So if I see PAP-A less than 0.4 multiples of median at the time of nuclear, I always write a comment on the report. This increases risks of IUGR. Please do third trimester growth scan at 28 weeks and 34 weeks. And often we see development of the IUGR in those patients. But disadvantages, obviously, compared to NIPS or amnio, the detection rate is less. So NIPS, what are the advantages and disadvantages? It's a non-invasive. It's a blood test. Doesn't harm the baby. And then it's got a very, very good sensitivity detection rate for trisomy 21, more than 99%. But disadvantages are, it is expensive. Currently, it costs about somewhere between 400 to 500. When it came 2 years ago, it was like a 1500. So it came down quite a lot, but still very expensive. And a lot of people can't afford it. From trisomy 13 point of view, it is less sensitive. Now, and then if the test comes back positive, they still need amnio. NIPS may not be suitable, especially in some situations. For example, in the case of the fetal abnormality, or risks of the trisomy 21 is very high, or if the nucleus are very thick. Mainly because often those babies may not have trisomy 21, but have some atypical chromosome abnormality, some weird deletion, or duplication in chromosome 3 or 5 or something like this. And those things can be only identified by the amnio. So if there's a structural abnormality, there has to be some discussion or consideration of doing an amnio, rather than blindly recommending NIPS. Question is, so we know that NIPS is an excellent test in terms of the Down syndrome screening, but it's expensive. So in private setting, everybody gets NIPS. But in public setting, how can we incorporate this with the most cost-benefit way? So several people did cost-benefit analysis, but it's not easy to do good cost-benefit analysis because there are so many things to consider. There's the cost of the performing test, cost of the pregnancy loss with the invasive test, with the amnio, CVS, cost of the false positive result, because you got to counsel them, cost of the abnormal result, another counseling fee. You got to talk about the termination of the pregnancy, admission for the termination of the pregnancy, cost of the missing the diagnosis. So there is a direct cost, like a medical, education, hospital requirement for a baby with a trisomy 21. Indirect cost, impact on the family, loss of the income for next 50 years. Now, cost related to the delay in getting result, and then access to the test. For example, the nucleus done in metropolitan area is different from the nucleus done in rural area. And these are not easy. Not many cost-benefit analysis can include all those things. These are some of the options. There are school of thought where they recommend NIPS as a first-line universal test. So they're saying that get rid of the nucleus, just do NIPS. There's a school of thought that we still need a nucleus, we still need some sort of a scan around 11 to 13 weeks because they provide the dating, some anatomical surveillance, and then do the NIPS for those who have a high risk. If it's very high risk, maybe doing amnio, but some sort of intermediate risk, rather than recommending amnio, to the NIPS. Some sort of a contingent NIPS. But nobody knows where to draw the cut. Is it 1 in 10, 1 in 50, 1 in 300, 1 in 1,000? Nobody knows. There are some guidelines. So RCOG guideline 2014. So this is what they say. Now, women already knows about these tests. So obstetricians should have a knowledge. And they think in the near future, NIPS will become the primary screen. So I think that's what the UK people are thinking. This is what the American people are thinking. So they said in 2015, there's a limited data on cost effectiveness, especially in low-risk population. So they still recommend conventional screening method, which is nucleus. This is what the Australian people said, Ranscock statement. So they say women should have a timely access to the test And then prenatal screening options should be discussed. And they don't specify whether it should be nuchal or NIPS. They are very vague because they are not sure what to do. It's up to you to discuss and decide what to do. What would you do? For example, there's a lady, primate, she's 8 weeks pregnant. She came to you, first visit, and she asks you, doctor, I'd like to do some Down syndrome screening. Who would recommend NIPS?
Is she overweight?
60 kilograms.
Does she have enough money?
Yes, that's very important to discuss.
Just
Once,
repeat the questions.
sorry, I forgot your name.
Mike.
Dr. Mike asked whether she's overweight or not, whether she had enough money. If she had enough money, what would you do?
It would still be further things that you'd have to discuss with her. You could do the initial test, and
Yes.
if that's clearly negative,
Yeah.
then you could offer it to her. It's still her decision in the end.
Yes, I think so. If it's my wife, I'll do both. Because I like to have a look at the baby just to make sure the dating is correct, just to make sure there is no anencephaly, to make sure that there's no twin. And then I'll do the NIPS. If I have a lot of money, that's what I'll do. But if the woman does not have money, it's very hard. It's very hard. I don't know answer. Yes?
Where did we send it to the NIPS?
Where do we send for NIPS? That's a good question. Currently, there's 2 labs where the lab is based on the Sydney. There's a company called Guinea. I think it spells G-I-N-E-A. It's a fertility company. They provide NIPS service. Also, Douglas Henry Moyer, they do NIPS. Okay, the forms are available in their website. All you have to do is go to their website, print the form, and then talk to the patient. I think they have to call the lab and then make an appointment. I think they do ask a credit card number before they making an appointment. But it is readily available, Douglas Henry Moyer. So that's what I use.
What about this advertisements we hear about Harmony?
Harmony is a Douglas Henry Moyer.
Oh, okay.
Yes.
Can I ask if that's also part of the, the delivery package that is with the private insurance?
Correct. So if you go, so the question was, often NIPS is a part of the packages in some fertility center. For example, I don't know whether I should talk or not, but if you go to the Guinea, it's part of the packages. So you can choose to do it or not. So anyway, I've got nothing to do with the Guinea or the Harmony. Any other question?
I think the high risk
Yeah.
are those over 35
Yeah.
have a family history. I think they should be offered.
NIPS, yeah. I mean, it's between you and your patient at the moment, unfortunately. But I think, especially, you're absolutely right. High-risk patient, like over 35, if I'm the patient, I'd be upset if I wasn't informed about these options. That's how I would feel. Anyway, we'll keep going.
And as
Yes.
as you mentioned, the ultrasound piece of actual abnormality, so it should be offered by the
That is true.
Repeat.
Sorry, I forgot your name.
Shubha.
Dr. Shubhan asked, Dr. Shubhan stated, ultrasound also should be offered because it provides early anatomical surveillance, which is something that you cannot ignore. So it's
With the Zika virus and microcephaly.
Zika virus and microcephaly. Yes, it's another topic. we can do this if you have enough time. Yeah. And I'm not keep going. I mean, it's very controversial. Nobody knows what to do. Nobody knows what to do. But there's a lot of ethical issues. So there's issues of the inequality of the access. Because a woman has to pay $500. That's expensive. Some people can't afford it. And then, there's a risks of creating dissatisfaction. You're telling the mom that there is a good test, but it's expensive. You can't pay it. She gets upset. And then I think sometimes the other thing is that often the blood test is done without proper counseling. So somebody heard about this new test, and she's only 6 weeks, and they just, organize NIPS, failed test, wasting of the $500. Those things happen. Now, the other issues are, because the NIPS can find out the sex at very early stage, like 10 weeks, it opens the floodgate of the sex selection. It's a problem. And then the other thing is that because they are checking the free DNA, often, and not often, but there is a small possibility they find the abnormal maternal DNA, things like 47XXX, and sometimes abnormal DNA comes from cancer cells. There's about 1 in 10,000 chance that because they did the NIPS, they got diagnosed with things like bowel cancers or leukemias and breast cancers and that sort of thing. Now, again, we're talking about the atypical chromosome abnormality. So now, if there's a high risk of a trisomy 21, the risk goes up because there's a risk of a trisomy 21. But often, sometimes that happens because of the other chromosome abnormality. So if the risks of a trisomy 21 are very high, like more than 1 in 20, the chance is like 4%. If it's 1 in 200, 1.8%. So those people, I think the option of the amniocentesis has to be discussed. Again, it's a similar thing. If the nucleus are very thick, the chance of the atypical chromosome abnormality goes up. So in this case, amnio might be more appropriate than NIPS. Now, twins. Now, again, it's a difficult question. Twin, do we offer NIPS or not? Now, the numbers, so up until 2015, the number of the studies of the twin NIPS, there's only 5. And if you look at all of them, 400 euploid, 31 trisomy 21, 9 trisomy 18, and 2 trisomy 13. From trisomy 21's point of view, detection rate was a 93%. Not too bad, but only 30 trisomy 21s were tested. Trisomy 18, trisomy 13, all of them are detected, and because of this, commercial lab might say detection rate for twin trisomy 18, trisomy 13 is 100%, but it's only 2 babies in trisomy 13. You can't comment about this. You can't comment the sensitivity with this. So, twin NIPS are commercially available, but most guidelines state that there's not enough data about the accuracy about the NIPS in twin at this stage. Commercial lab offer them, but I don't recommend them. That's what I do. Now, the NIPS also can detect some atypical chromosome abnormality, so-called microdeletions. And there are 5 conditions that are testable through the NIPS. Again, the lab state the detection rates are very good, 97, 99, 94, 99%. But again, the number of the patients who are tested are small. So I think, again, for this kind of a condition, the NIPS is too premature. The future. Now they are looking at human genome with the NIPS, looking at every gene available in human. So it's possible, but ethically controversial. So you do the NIPS, you look at every gene of the baby. Oh, there is a cancer gene. There's a schizophrenia gene. What do you want to do, mom? It's a big problem. Nobody knows what to do. Anyway, so we're talking about the NIPS. So how shall we counsel them? If you have a look at the RANSCO website, there is a good guideline about aneuploid screening. And this is the extract from there. Before we doing an NIPS, I think it's imperative that you do the dating scan. Make sure it's a live baby. And then make sure it's not a twin. And then I think you should discuss those detection rate and failure rate. This is what I tell Mrs. Smith. This is a new blood test introduced in Australia for the last few years. It's a blood test. So they take the blood from the mother and they identify the baby's DNA and find out whether the baby's got Down syndrome or not. From Down syndrome point of view, detection rate 99%. Trisomy 18, 98%. Trisomy 30, 90%. Sex chromosome, 95%. So it's quite good test. It is technically more accurate than nuclear. But Medicare doesn't cover. So currently $500. If you do this test, we do this after 10 weeks. There's a 1% chance the test will come back as a failed result. There's nothing much I can do. There's a 1 in 10,000 chance the test shows some abnormal DNA in the mother. And there are case reports where it turns out to be things like breast cancers and bowel cancers and something like this. That's what I tell the patient. Anyway, it's up to you to how to, the way to discuss is that it's all up to you, but that's what I do. Now, I got to tell the patient that this test is a screening test. It's not a diagnostic test. So that they need to know that if the test comes back positive, it still needs to be confirmed with amnio, because a positive predictive value for trisomy 21 is 50 to 80%, and it's worse for trisomy 18 and trisomy 13. If the test comes back as a low-risk NIPS, that's a good thing. You can reassure them. And our college said you don't need additional risk calculation. In other words, our college recommend don't order nuclear. That's what they say. Provided that you confirm that this is the viable pregnancy, provided you confirm that this is whether it's a singleton or twin. Because all those things should be done before NIPS is done. There's an argument that if you don't do 11 to 13 weeks, if you don't do the scan at 11 to 13 weeks, things like anencephaly, thick nuchal or gastroschisis are missed. In reality, those things are rare things. And eventually you got to think about cost-benefit analysis. So because of this, college does not recommend nuclear if somebody had an NIPS. But again, it's a guideline. Now, if there is a presence of the fetal structural abnormality, it is an indication for invasive prenatal testing, like NBMPHN. And pre-test counseling should also include informed decision-making regarding fetal sex test. And women should have a choice to not to or not to receive this information. Does it make sense to you? Any questions so far? All right. We'll do some cases. This is live cases. Now, case 1. 25-year-old. She had one normal delivery before, and she had a nuchal. And this is a nuchal report. Nuchals are 2.5 millimeters. This is normal. And these hormone tests are within normal because she's 25-year-old. Her age risk is around 1 in 1,000. And all the numbers are good. Her final probability of the baby being Down syndrome 1 in 15,000. How shall we counsel this patient? Anybody would offer NIPS? Nobody. Would anybody offer amnio? That's what I would do. So she had a normal baby. I would not offer NIPS. I would not offer NIPS or amnio. That's what I would do. But this is how I would counsel them. Mrs. Smith, this is a screening test. This particular test is designed to give you a probability. You have to understand that this is not a yes and no answer. But technically, there's a 1 in 15,000 chance that baby being Down syndrome. Some people do ask whether there is anything I can do to find out more information. There are two ways if you want. There's a test called amnio. It's a needle test. Needle go through your skin, go through the uterus, and take a small amount of the fluid around the baby. And that tells you yes and no answer. But there is a risk of miscarriages, about 1 in 200. So somebody like you, where the risks of the probability of the baby being Down syndrome is 1 in 15,000, if you proceed for the needle test, technically the risk of a miscarriage is higher than you having a baby with Down syndrome. So in most situations, a lot of women does not choose to have an amnio, and then I wouldn't be recommending amnio unless you really, really want a yes and no answer. And most people, in my experience, does not choose amnio. There is a second option, Mr. Smith, called NIPS. It's a new blood test introduced in Australia for the last few years. They take the blood from the mother and then identify baby's DNA and find out whether the baby's got a Down syndrome or not. From Down syndrome point of view, it's 99% accurate, very accurate. So it can give you extra information or reassurance. But unfortunately, Medicare does not cover this. In my experience, most people, when the numbers are like this, they don't choose to have an NIPS. But there are situations where family wishes extra reassurance or information, and sometimes they are willing to go the pathway. There's no right and wrong answer. What do you think? That's my spell. Majority of the patients don't choose NIPS, and I found they are generally happy with that sort of explanation.
When we give the background risk, do they take into consideration the family history?
They do. Yes. The question was, when they calculate the background risk, what do they consider? They consider age, BMI, and then previous history of the Down syndrome. Now we'll do the next case. Now this is a 40-year-old lady. She also had a one-term delivery before and had a new curve. This is exactly same number. But because she's 40-year-old, her background risk is 1 in 80. Her final probability is 1 in 450. Now, this is still low risk. Less than 1 in 300, they are all considered as a low risk. Now, should we offer amnio?
It should be discussed.
Should it be discussed? I think that's important. Should we discuss the NIPS?
Yes.
I think so. I think that's what should have happened. She was told, unfortunately, by the junior medical staff in the hospital, this is a normal result. Don't worry about it. That's how she understood. Baby had Down syndrome. She was really, really angry. She was angry because she was told the patient was normal. She told us that if I known about there is an option of amnio and NIPS, I probably would have taken it. That's what she told. You never know. Easy to say retrospectively, but it's something which can bite you very easily.
Can you be legally pulled up for this?
I'm not too sure. Honestly, I don't know.
Not giving
Yeah.
alternative
Yeah,
option.
and I have to. No, I don't know, to be honest. Yeah, I think I have to. The question was, is this legally dangerous if we don't talk about it? I think you have to talk with your indemnity insurance and ask what they think. To be honest, I don't know. I think I might have to find out. But those discussion takes 5 minutes, and I think it can save you. Case 3, yes.
Sorry,
Question, yes.
usually if there is a suspicion of a high risk in the ultrasound obstetrician thinks that she's at high risk, they do send a letter to say
Correct.
synthesis
Yeah.
recommended.
But now, when the question is, Often there is a high risk. The radiology center discuss with the patient about the options. Now I think that's what should happen.
But this is in between.
This is technically a low risk. Well, anything less than 1 in 300, they are all collectively called as low risk. Now, what do they do in radiology center? If it's a private, most private radiology center, do not discuss the result with the patient. They just generate a report and leave it to the referring team to discuss the result. There are some radiology centers who do discuss the result, and there is a Medicare item. But most of the radiology center, they don't discuss it. In Nepean Public Hospital, we like to discuss every nucleus. We go through the spell I said, we go through every patient with those discussion as much as possible. But there are situations where we couldn't do it because of the blood test is not available, or patient has to leave or something like that. In that case, we don't charge it for the Medicare item for this. But we write a report that this is low risk, but this has to be discussed with by referring doctors or something like this. Okay? Does it make sense? Does it answer your question? That's good. Yes. Was there a question? Yes.
So we have a question online from Dr. Say,
Yes.
which is, does private health cover NIPS? So does private health cover NIPS?
I don't know.
Hang on,
I'm so
hang
sorry.
on.
I don't know.
Hang on just one moment.
You can ask, I suppose. Yeah.
Could you answer that again now?
I don't know the answer, and I'm very, very sorry. Yeah. Does anybody know? Does anybody know the answer? Nobody knows. I am so sorry. I'm sure you can call the insurance company and find out. Yeah. The whole thing is evolving so rapidly. Every 6 months, something new policy comes up. So it keeps changing. Any other question? Shall we go next case? Next case. Now, she's a 33-year-old, G2P0. Now, she's G2P0 because in her first pregnancy, she had a stillbirth at 32 weeks. So basically, when she was 30 weeks, she developed a really small baby and really terrible Doppler on the umbilical cord. And the hospital watched it, and unfortunately, there was a very sudden, unexpected stillbirth. And autopsy showed that that baby was a trisomy 21. And then she got pregnant again.
But did she have an NT scan with this pregnancy?
No.
Question?
The question was whether she had a nuchal in this pregnancy. She did not take. So in second pregnancy, she did the right thing. At 8 weeks, she went to GP and asked about what to do. And GP has recommended the nuchal. So this is a nuchal report. 1.8 millimeter nuchal thickness, which is within limit. Beta ICG 1.8 multiples of median, not too bad. PAP-A 0.3 multiples of median. There is a guideline about what to do in PAP-A. There's a thing called green top RCOG guideline of the small baby. That guideline says if the PAP-A is less than 0.4 multiples of median, you have to watch the baby's growth carefully. So this is low. So she has a high, sorry, what am I doing? So she has a high risk of developing, not high risk, but some risk of developing small baby later in the pregnancy. Overall, however, the risks of trisomy 21 came back 1 in 817. And she was told, this is low risk, don't worry about it. That was it. At 24 weeks, same thing happened like a first pregnancy. Exactly same thing. Very small baby. And then very abnormal umbilical artery Doppler. And that's often what trisomy 21 fetus do. They're small, and often their Doppler is abnormal. And again, she got very upset because she was not told about the options of amnio or NIPS. Anyway, this baby delivered at 32 weeks. It was a normal baby. But those things, again, can bite you. Not discussing properly after the new cut. Case 4. 35-year-old, primate. For some reason, she booked it late, 14 weeks. And then she came to the hospital, and midwife did the first visit. Oh, I'm sorry, Mr. Smith. You just missed a new call. Don't worry. There's another ultrasound at 18 weeks. We'll organize this. So she had a morphology scan at 18 weeks. What could have been done differently? Correct. And new calls are only available between 11 to 13 weeks. After 13 weeks, you just can't do it. Program can't accept it. NIPS, you can do it any time after 10 weeks. 15 weeks, 20 weeks, 36 weeks, 38 weeks. You can do it any time. And then, another trisomy 21. And she got upset because she wasn't offered about the NIPS. Before the NIPS is available, I think the correct answer will be discussing about options of a second trimester screen, like a triple test or a quadruple test, which can be done between 14 and 18 weeks. Personally, I don't like this test because the detection rate is not very good, 65%. But it is a Medicare benefit. It is free for the patient. So it's something that you can consider. But in the presence of NIPS, I'm having a difficulty strongly recommending this one, to be honest. Next case. 39-year-old, primate. She had IVF. She's very anxious. Doctor, I'm really anxious. I need a very, very good test for the Down syndrome. Do you know amnio? No. Do you know NIPS? Yes. So she had NIPS. But NIPS came back, trisomy 13 baby. What shall we do? Correct. You don't terminate based on the NIPS. Never terminate based on the NIPS because positive predictive value for trisomy 13 is somewhere around the 20 to 60%. Normal baby. I had, for last 2 years, I had three patients who had NIPS, and NIPS had trisomy 13. 2 of them was normal. Only 1 of them had a trisomy 13. So trisomy 13, you have to be careful with the NIPS. Next case, 28-year-old primate, she had a nuchal. So nuchals are okay, beta is a little bit low, 0.3, papa a little bit low, 0.4. And risks came back, trisomy 21, 1 in 1,500, so low risk. Trisomy 18, 1 in 146. So trisomy 18 is high risk in this case. Trisomy 13, 1 in 340, technically low risk of a borderline. Shall we offer amnio? No? So amnio diagnostic test, 100% accurate, but 1 in 200 chance of miscarriages. But that's one option. Shall we offer NIPS? It's non-invasive, purely from trisomy 18 point of view. It's not too bad, 98% detection rate. So not too bad, 98% detection rate.
So I don't know the manifestations of
trisomy 18. So question was, what's the manifestation of the trisomy 18? That's a very, very good question. And I'll explain now. So there's a first option is amnio, second option is NIPS, and third option is, which is a very legitimate option, is you don't do anything, you wait 18 weeks and having a good look on the baby. It is very, very difficult to get a trisomy 18 or trisomy 13 baby if baby looks plumb normal at 18 weeks. So there's a thing called likelihood ratio. There's a thing called negative likelihood ratio. So if the baby looks plumb normal, all these things technically become like it goes down by 3. So 1 in 150 becomes like 1 in 500, 1 in 600. Okay? Very difficult to get a trisomy 18, trisomy 13 baby if the baby looks plumb normal. So you wait, so third option is that you wait until 18 weeks. And if the baby looks completely normal, technically your risks of a trisomy 18, trisomy 13 becomes very, very low, way low than the risk of the miscarriage coming from the embryo. Then you decide what to do. That's the third option. And it's not an unreasonable thing to do. And that's what this patient did. So she decided to wait until 18 weeks. Baby looked completely normal, and then had a normal baby. Now, trisomy 21 is a little bit different. If the trisomy 21's risk is high, and then, as I say differently, half of the trisomy 21 baby looks completely normal at 18 weeks. So trisomy 21, normal ultrasound, you can't reassure them. You can't reassure them. But if it's a trisomy 18, trisomy 13, I think you're a little bit more confident, as long as you believe your sonographer. If you can't believe your sonographer, you can send us to Nepean fetal medicine team, and we can have a good look. Now, so that's it. Any other questions?
Just for the benefit of it, we offer for all patients, even young patients, 18 years and at least an NT at 11 weeks.
I think everybody should have, the question is, do we offer all patients to NT, including very young age, like less than 18 years old? Now, the college guideline is, yes, every pregnant woman are recommended to have some sort of discussions about the aneuploidy. That's my answer. Chances are low. But the problem is, if you look at the patients who had a trisomy 21, often it's a young baby. Often it comes from a young mother, because majority of the pregnant women are young mother. Now, people can have a different opinion, but again, I would recommend it. I would recommend some sort of a screening test. Maybe not the NIPS, but at least the nuclear. Any other question? Yes?
So would it be reasonable to offer, aside from that, to offer NIPS for patients 35 and 40 years old?
So if the question was, if the women are more than 35 years old or 40 years old, would it be appropriate to offer the NIPS?
Yeah, I think it has to be mentioned.
That I do. If somebody specifically asks you, now, doctor, I am interested in Down syndrome screening test, what would you recommend? Then, now, I have to say, regardless of the age, I let them know that there's options for this and options for this. To me, it's unethical to say one patient that there is this test available, and the other patient, I say this test, I don't mention about this test. Because technically, NIPS is far superior than nuclear. There's no doubt about it.
Does it cost
Far
to
superior.
have these tests?
Yes. Unfortunately, Nepean Hospital does not provide a cost for the NIPS. Patient has to pay. I hope in a few years' time, the government create a Medicare item for the NIPS, but not at the moment. Where is it? Now this table. So, if you're doing a nuclear, 20 Down syndrome babies are missed. If you're doing an NIPS, almost all Down syndrome babies are detected. Okay? So to me, I feel unethical not to mention of the option of the NIPS to one patient while I talk about the other. That's how I feel.
So following my question that I asked,
Yes.
a lot of times patients present quite late, after 12 weeks.
After 12 weeks, correct.
So even young people should tell them about this NIPS.
That's what I'll do. That's what I do.
Well, a lot of these people refer young people.
Yeah, it's hard, yeah. Again, I don't know what the right answer is. I'm very sorry. I wish I can tell you, this is the guideline, this is the evidence, but this thing, it is a new thing. It's only developed for the last few years, and people just don't know where to put this test on the system properly. Nobody knows. But in a 5 years' time, in a 10 years' time, I hope some sort of a proper system comes. That's what happened in Nuclear. When Nuclear came initially, 10 or 20 years ago, people just don't know what to do. But now it is established test. These things take time. I think that's the nature of the new test. We can't avoid it.
You advise people present late to you.
Yes.
Young people.
I tell them. That's what I do. So the question was, if there's young people saying 18-year-old girl came, she just missed the Nuclear, she's a 14 weeks, 15 weeks, do we offer NIPS? Yes, I do. I let them know. Yes.
Offer NIPS. You said earlier you likely to need the ultrasound first to make sure it's not treated.
Correct.
That, if it's not dating, the Medicare doesn't cover either.
Does it?
There's another extra cost.
Ah. That I'm not too sure. The question is that apparently the dating ultrasound before the NIPS, there's no Medicare item. Is that true? Holy moly.
For dating. If you're not doing it for dating purposes, I'm not sure.
But you got to do the scan anyway, but you got to do the dating anyway for everybody. Aren't you?
No, it's not covered by Medicare.
The dating ultrasound is not covered by the Medicare?
Unless the patient has unsure irregular periods.
Okay.
Not covered. Only the NT and FAS is covered by Medicare.
Oh.
Should have a bleeding or
I don't know. I'm so sorry. Yeah, I'm so sorry. I don't know. Yes.
But can we do an NT scan and then do an NIPS?
I mean, you can do that. I mean, you do the. I mean, the question is, can you do NT scan and decide what to do about NIPS? That's perfectly reasonable. You do the NT scan, and then if the NT scan says the risks of the baby being Down syndrome is 1 in 15,000. I mean, most people don't do the NIPS, logically, unless she's really super anxious. But if the risk comes back 1 in, say, I don't know, 400, those are actually not a bad situation where you can discuss about the NIPS. Was it too much for the annual? But some people may feel a bit unsure. I'll be unsure. So, you talk about NIPS. Does it make sense? But again, there's no right and wrong answer. And it does depending on how the patient feels about this 1 in 400. I've got 10 minutes.
What is your
Yes.
What is the cutoff for your BMI to start worrying that the NIPS might be?
If the BMI is 40, the question is, what's your cutoff about the BMI in terms of the doing a NIPS at later gestation? There's no guideline. But what I think is that if it's BMI more than 40, I do that at 13, 14 weeks. Definitely not 10 and 11 weeks. That will be more safer. Now, I think I better keep going. Yolanda is keep looking at me. So I have to talk about this pertussis vaccination. Now, can I ask, are we giving a universal pertussis vaccination in GP shared care program? Yes, that is correct. That's good. So you all know that. I'll just very quickly go through the pertussis. Yeah. Now, pertussis, you all know this. You know better than me. It's a disease caused by the Bordetella pertussis. It's characterized by the paroxysmal coughing, sometimes bronchopneumonia, and there's distinctive whooping intake of air. It's not a serious disease in adult or adolescent, but very serious with a high mortality in infant, especially less than 6 months. Incubation period is 7 to 20 days. In unvaccinated person, this thing is very infectious, with a 90% chance of infection. A natural infection does not provide long-term protection. And I mean, these pertussis account 7% of the cough illness in adults. And then if it happens in the unvaccinated infant, there is a case fatality, up to 1%. And epidemics occur every 3 to 4 years. And the most frequent source of the infection in infant pertussis is household contact, mom and carers. So you got to vaccinate them. Now, DTPA, it's only available pertussis vaccination, so Boostrix. And then based on the Australian Immunization Handbook, the most recent one, that's what they say, vaccination of the pregnant woman with Boostrix has been shown to be effective in preventing pertussis because you give a vaccination at late trimester, 30 weeks, 32 weeks, mom develops antibody, this antibody goes through the placenta, goes into the baby, stays in the baby for first 3 to 6 months so that they can be protected. Because you can't give a Boostrix until baby becomes 6 months or 12 months, I can't remember, something like that. Okay? 6 months? 6 weeks. So you can give a Boostrix onto the baby as well?
Yes.
Ah. Sorry, my fault. Sorry, I'm bad. I'm so sorry. I should have checked it. But that's the theory. Mom developing the antibody, and this thing goes to the baby and protect the baby, especially for first 3 months. And this is a landmark trial. So in the UK, there was a sudden increase in infant mortality because of the pertussis in 2011. So they made a universal vaccination program for all pregnant women, 28 and 38 weeks. And this is what happened. Everything got better. 2012, so this is before the vaccination, this is after the vaccination. Number of the pertussis infection all go down. Number of the pertussis infection in infant, 120 to 72, almost a 50% reduction. Death, 10 to 3. Hospital admission, 440 to 140. So everything got better. So that's what the American guideline also said. So healthcare personnel give a Boostrix during each pregnancy, irrespective of whether patient had a Boostrix before or not. Because if you give a Boostrix, over the time, the immunity goes away. And to maximize the maternal antibody response, optimal timing is between 27 to 36 weeks. So at least 7 weeks before the delivery. There's no adverse effects on the baby. And if the woman's missed Boostrix, they should be administered immediately postpartum, because the most frequent source of the infection to the baby is mother and all other family members, grandma, grandparents, or everyone else. They all should have a Boostrix if they had a baby.
Is it routinely given in hospitals?
Yes, correct.
So it's not being given by us, you will give it in
we do. That's what we're trying to do.
No, but a lot of women come back and saying they're ready to receive the vaccine. We give them post.
Really? They should do better. They should do better. Sorry, I can't run whole department. Yes.
Well, you say regardless of their, when they had the Boostrix injection, what if they only had it about a year or two before?
You should give it.
Still give it?
Yes, if the woman had a Boostrix a year ago, the immunity can go down. So advice is, you still give it somewhere between 27 to 36 weeks. It's very clear. This is yes, you give it.
So that means the next pregnancy?
Next pregnancy, you still give it. Every pregnancy, you give it.
Oh,
Oh, really?
the carriers too?
Carers, yes, absolutely. Grandma, you give it. Husband, give it. Everybody, if you have an infant, every adult in the hospital must have a Boostrix.
Why can't you give it earlier?
Why can't you? Because infection. The question is, why can't you give it earlier, like a first trimester or second trimester? Because the immunity goes down. The whole idea is you give her about 7 or 8 weeks before the delivery. So mom made a lot of antibody, and they all goes to the baby, and the baby carries this antibody for the first 3 months. That's why you should give it at third trimester.
What if mother gets whooping cough in the first trimester?
First trimester? What if the question is, what if the mom gets whooping cough in first trimester? Then I think based on the ACOG guideline, you don't have to give it. you don't have to give it if it's the first trimester. But ideal timing is third trimester. That's what it says.
For the carers too, is the same thing?
Sorry?
For the carers too, is it the same?
Correct. For the carers, same thing.
In the pregnancy.
Yes, well, maybe yeah, later, so about 7 or 6 weeks before. 7 or 6 weeks before, yeah.
But I thought immunity for the boostrix is at least 5 years.
Well, based on this guideline, it can, I think it's lasting for, there are case reports that immunity goes down quickly, and then the baby gets infected from the parent. So there's a very clear guideline, and each pregnancy, regardless of whether they had the boostrix or not, at each pregnancy, at the third trimester, you give a pertussis vaccination. Yes?
I think that's referred to the mother.
Yes.
I think for the father in our household, according to the immunization,
Yes.
if they have it within 5 years, they're still fine.
No, I might be wrong. I might be wrong. Okay? Yeah. But I think the whole idea is you want to cocoon the baby. You want to cocoon the baby. You got to make sure that everybody's all immune to boostrix, especially for the first 6 months, because that's the time that if the baby gets whooping cough, they get really sick and can die. And yes.
Boostrix is out of stock, which happened before. Can we do Boostrix IPV every time?
Boostrix.
That's my question.
So what's the question?
Polio, it's
The polio. I have to look it up. Boostrix out of stock, so can you add a boostrix with a polio? Or to the mother? I have to look it up. Polio, I think it's a live vaccine. If it's live vaccine, then you shouldn't give it.
No, oral vaccine is live, but not the
Injection? Yeah, I have to check. The vaccination program is so. The immunization guideline is very, very well written. I think I have to follow that, but I have to check whether it's safe to give the one with the polio. Okay, but I have to look it up. I'm sorry, I have to look it up.
Can I?
Yes.
There's the boostrix and there's the boostrix IPV.
Yes.
And that is not a live polio vaccine. That is a cellular.
Just a
with boostrix.
Yes. Now, if it's not a live vaccine, the rule of thumb is no problem, but I have to check it because I don't want to give you the wrong information. I have to look at the guideline. Yes. Yes. Yep.
You unmute me and turn my speaker up. So just on the question of what to do when the boostrix vaccine is out of stock, I think this would be something for the public health unit, but also something for our immunisation project officer here at the Primary Health Network to advise general practice about. Currently that's Jackie Genossi and Andrew Warrilow. I haven't heard that it's out of stock at the moment, but are you saying that it definitely is? Okay, so we might get something. I'll take that on, and would it work if we put something in our weekly practice news bulletin that goes out to general practice advising what to give? So I'll talk to Jackie tomorrow, get her to look into that. I'm sure that there is a Ministry of Health response on what to do, and we'll just make sure that gets fed out to general practice and to yourself.
No problem. Thank you very much. Yes.
Okay.
My name is Cecile, I'm the GP. I hope that I can clarify a bit about it. The boostrix in each GP practice we are giving it free, and we keep it for our babies.
Yes.
So therefore, the boostrix IPV, which is correct, out in the market at the moment, the plain normal boostrix is completely out of stock.
Really?
So only the boostrix IPV is available outside of the general practice. So therefore, the pregnant women falls into the safe guideline of either having it at the hospital, and in which case, like you were saying, it's only boostrix, or if by chance they, or by unfortunately they miss yours, and they come to our practice, then we give our own stock, and our own stock does not have IPV in it. So I think I feel safer to follow your guidelines, and now that our practice is safe in that way. And the parents and the husbands and the grandparents, I usually write out the district's IPV with the polio because they're not at risk.
No.
So this is how we navigate in between the two guidelines.
Okay.
Yeah.
Thank you so much for the explanation. I appreciate it. Yes.
Okay, so I just have one more question before we hand back to you, Stephen, and then it's probably about time to wrap up.
Sure.
I'm sure Stephen's happy to stay in the room to answer some more questions.
Yeah.
So we have a question from Dr. Russell Thompson, or a comment, which is, my understanding is that other household contacts only need a DTPA booster every 10 years. He can confirm that DTPA is not available via commercial pharmacies in Australia at the moment, which we've just heard, because the hospitals have stockpiled it. We won't comment on that. And then the other question from Dr. George Sayer is, do you immunise brothers and sisters of the baby who had their primary immunisation? But I would imagine the brothers and sisters would be immunised anyway through the normal vaccine schedule. Okay.
I think it's better. I have to check.
Hang on, just
household care. Thanks for the clarification.
Okay, so we will check about other household carers. And now I will hand back over to Dr. Joung for your final.
Okay, so final part.
And just
a referral pathway for the high-risk obstetric patients. The hospitals do have some guidelines about which patient. Sorry. There we go. Okay, so now hospital has 3 types of the clinic: low risk midwife clinic, medium risk doctor's clinic, and then high risk maternal fetal medicine clinic, which I run. And then there are some criteria that which patient should be referred to high risk clinic and potentially medium risk clinic. But you all know this, what's high risk. For example, people with a recurrent pregnant perinatal loss, history of the stillbirth, preterm delivery, cervical incompetence, things like a placental or cretas and things like that. They need to come to us. Patients with a significant maternal medical condition. Previous obstetric history with a significant issues, things like atypical antibodies, like Rh, anti-D, anti-K, and that sort of thing. Previous baby with a congenital abnormality, genetic disorder. Previous baby with alloimmune thrombocytopenia, or preterm delivery because of some sort of a placental disorder, like IUGR, abruption, preeclampsia. And then current pregnancy with a significant complication. So current pregnancy with a fetal or genetic abnormality. Complicated twin, or suspected infection with a CMV, parvo, toxo, syphilis, HIV, and that sort of thing. So if there's any question, I'm happy to be called. I'm happy to be called. So you can contact the hospital switch. I get a call from the Lithgow GP at least once every week, and then from the Orange Hospital once every week. I'm happy to be called. So if I'm not available, please leave. You can leave the message, and I'll try to get back to you. If it's urgent, on-call ONG registrars are always available 24 hours, and their job is to get a call from our side as well. Now, if any referral is required, this is a fax number that you can use. And all those high-risk referral, they come to me. So there's a tray where they put the referrals to potential MFF clinic referral. And I see them every day, and I triage them. This is fax. This is antenatal clinic fax number. Antenatal clinic fax number. So I'm happy to be called if there's any question. Yes?
If you have somebody who is basically a well person who's over 40, would you consider them high risk?
That's a very controversial area. Now, the question is if the BMI is over 40.
No, the patient is over 40 years old.
Patient is over 40 years old. Do we consider that high risk? I think it is. I think it is. The hospital is in process of making a guideline of the advanced maternal ages. So they are talking about these things at the moment. I think it's worth reading what they say. But advanced maternal age is something I can't ignore. Yes?
At what stage of pregnancy will we accept patients at the high-risk clinics?
Any stages.
I've tried to get people in there that I was not back before 20 weeks.
Really?
Yes.
So what was the patient's problem?
Pregnancy hypertension.
They shouldn't. They shouldn't. If there was a problem, I would like to know about this. Because they shouldn't block you. They shouldn't block you. Okay? So at the moment, what I instructed to the antenatal clinic is all faxed referral from the local doctors. They go into, if it's a high-risk issue, if it's all faxed referral, they go to my clinic, my tray, and I see them. And if this fits the criteria for MFM clinic, I ask them to come within 1 to 2 weeks. If it may not fit, it may be not fitting the MFM clinic, but it might be something suitable for medium risk clinic, general doctor's clinic, then they should come to within like 1 to 2 weeks. So if there's any issue, that they should be seen at the hospital clinic within 1 to 2 weeks. And if there's a problem, I would like to know about this.
I just have one question.
Yes.
Some patients doesn't after they get pregnant and having taken continuing their medications.
Yes.
And you need some advice. Is there a number we can call?
So general obstetric question. Again, I'm happy to be called. I'm not available on-call ONG registrar. And on-call ONG registrars, if it's something really easy, they will advise you. But if there is something they need a consult, they either contact on-call obstetrician and then get back to you, or they can talk to me as well. Okay?
Okay.
Yes. Yes.
You need to have a checkup of blood tests.
Yes.
Between 10 and 12 weeks.
Yes.
Where should we send those patients if they need to have them to the hospital?
Douglas and Memorial. Douglas and Memorial.
So just repeat that.
The question was, if somebody going through the nuchal, if somebody need a nuchal test, are we talking about NIPS or nuchal blood test?
It's just a routine 10 to 12 ultrasounds.
So if somebody goes to that, I think it looks like a nuchal test. If somebody needs a nuchal test, if you want to organize the hormone test as a part of the nuchal, where should we send them? I have to say most commercial labs, they do it. Liberty or Douglas and Memorial, most commercial labs, they do this.
I understand.
Yeah.
Commercially they go to each other, but what about in the hospital if they want to go? Because privately,
Yeah.
a lot of authorities, they charge the money. The patient says, I can't afford it. Can you send me to the hospital? The hospital does these things.
Hospital charges some money for the blood component. There is some charge for the patient for the blood test component of the nuchal.
It's just a blood test. It doesn't have to be an ultrasound at the same time.
There is a time limit, so it has to be timed around the ultrasound.
1 week.
Yes.
Okay. I might ask you to take this off now and just step out here.
All right then. Yeah.
So I'm just going to step in and close things up from here because I'm aware that we did say we'd finish at 8:30. I'd really like to thank you, Stephen, for coming and sharing your knowledge and expertise and for being so willing to play in this new space of making the education available. We've had 14 people online at home from Katoomba all throughout the region. So thank you very much and for your willingness with that technology as well. You'll see for those of you in the room, you've got the yellow evaluation form. If you could complete that and leave it on the table outside, that would be fantastic. And for those of you at home, once we finish the webinar, there will be a survey, an evaluation in the form of a survey that you'll receive, and you'll also get an email reminder of that. I will follow up with our immunisation officer about the pertussis vaccine schedule and get something out to you all. And I think that's all I have to say. Thank you everyone for coming. I'm sure Stephen's happy to hang around and answer a few questions and have a chat.
Yeah.
But yeah, good night everybody. Thank you.
Can I ask a question about anti-D?
Yes.
Is there any way that we can access that a little bit more easily in the Blue Mountains?
So you can't give anti-D in the Blue Mountains?
Well, we don't have it in our practices. We have to send them to Toomba or Nepean hospitals, and if it's anywhere near after hours, they will tell them to go through casualty, and they'll have a 5 or 6 hour wait. I had a patient very recently who miscarried at 14 weeks. She was RH negative, and she was finally seen at 11 o'clock on Friday night after I rang Katoomba and Nepean hospitals. The suggestion from some Blue Mountains GPs is we have one central practice which has anti-D. It's done in country centres like large practices in Bathurst and Wagga have it in large practices that they have anti-D.